Milestones in Medicine is produced by American Medical Communications. This Milestones in Medicine program is funded through an unrestricted educational grant provided by Janssen Pharmaceutica. This Milestones in Medicine program is available for continuing medical education credit. Please see details following program. When pharmacologic therapies are prolonged, even relatively benign side effects pose a substantial burden. Over time, persistent side effects are likely to cause patients to reevaluate the benefits of their medication. Noncompliance becomes a formidable threat when the therapy is being administered to control psychoses.
There are a chain of connections that I think we can now link together quite reasonably. There are a number of studies that strongly suggest that distressing side effects, not surprisingly, lead to decreased compliance with treatment. Patients who feel comfortable on their medicines are more likely to continue taking them. In addition, there is growing evidence that lack of compliance with treatment and the relapses and recurrences of illnesses that result from that are associated with a deteriorating and less successful overall outcome. Patients who have multiple relapses, who become psychotic again and again, recover more slowly and recover less fully.
I believe that the fewer adverse side effects medication has, the better the patient compliance is. Jeffrey Lieberman at Chapel Hill now has, I think, demonstrated quite convincingly, as have others in the field, that the major importance of treating schizophrenia, or the major goal in treating schizophrenia, is medication compliance, that the earlier you treat a patient and the fewer relapses they have, which tend to occur with medication noncompliance, the better the long-term prognosis of the illness.
So if we can, right at the beginning, get patients onto a pharmacologic treatment that is comfortable for them to take, then we can know that they're more likely to stay on it, to comply with our recommendations, to be pulling in the same direction we are in trying to prevent relapse. And then if we can do that, prevent relapse, that this patient is going to have a much better long-term course over 5 and 10 and 20 years of illness. This patient is going to stay much closer to the individual he or she would have been without this illness. I wanted to ask you about some of the side effects they may cause.
In this program, Dr. McAvoy and Dr. Risch will evaluate the clinical implications of anticholinergic side effects, current techniques to minimize their impact, and how antipsychotic drugs differ in their propensity for causing these complications.
Well, I think the most prominent anticholinergic side effects can be divided usefully into those on the peripheral parasympathetic nervous system and those that occur centrally. The peripheral side effects tend to occur in a regular sequence as you increase the dose of anticholinergic drug. First, you see drying of the mouth, drying of the bronchial secretions. Then there's effects on the eye and the ability to accommodate and to focus using the muscles that constrict the lens. This will lead to blurred vision. You'll see in some patients an increase in heart rate.
For elderly patients who are more sensitive to anticholinergic side effects, things like constipation and urinary retention can turn, which would be uncomfortable for most of us, can turn into medical emergencies for those patients. So I think there's side effects that reduce compliance, and then there's more serious side effects which can be medically dangerous.
The most serious anticholinergic side effects usually stem from peripheral cholinergic blockage. However, the risk of anticholinergic side effects differs markedly between high-potency and low-potency antipsychotic agents. Although the incidence of anticholinergic side effects is below 5% with such high-potency drugs as haloperidol, it can be as high as 50% with such low-potency agents as chlorpromazine. Yet the potential advantages of high-potency agents in regard to anticholinergic side effects are often negated by their far greater risk of extrapyramidal side effects, or EPS. The reason is that anticholinergic drugs must be added to manage the risk of EPS.
The high-potency classical or typical antipsychotics are relatively free. They have some anticholinergic properties, but they're much less, and they're much less clinically significant. The downside of these medications are that they tend to cause what we call extrapyramidal symptoms due to their dopamine blockade in the basal ganglia system. And those extrapyramidal symptoms then often cause us to use adjunctive anticholinergic medications to treat the Parkinsonian-like condition.
A problem with the low-potency drugs, the low-potency antipsychotic drugs, is that there is a fixed ratio of the anticholinergic, anti-Parkinson effect of these drugs to the relative antipsychotic activity they produce, and we're not able to adjust that because it's an intrinsic, built-in pharmacologic activity of those drugs. And I think that's why, in general, psychiatrists have shifted more to a use of the high-potency antipsychotic drugs when using a conventional agent, because then the psychiatrist is able to adjust the dopamine blocking level to the point that he or she thinks is best, and has full control then of how much anticholinergic, anti-Parkinson activity to bring to bear at that time to relieve the patient's extrapyramidal side effects, and hopefully to not overshoot into a level of anticholinergic toxicity that's not necessary.
The alternative to both low and high-potency typical agents are the atypical antipsychotic drugs, which appear to owe their antipsychotic effect to activity on a broader spectrum of neurotransmitter receptors than typical drugs. The currently available atypical agents are risperidone, clozapine, and olanzapine. The greatest experience is with clozapine and risperidone, because olanzapine was only recently approved. Comparisons of these two agents suggest they differ in many important ways, including their intrinsic risk for producing anticholinergic side effects. However, each provides a more favorable balance of safety and efficacy than conventional drugs.
One of the problems with the conventional antipsychotic drugs is that the dose-response relationship for the therapeutic effects, the desired effects of these drugs, was essentially on top of or overlaid upon the dose-response relationship for unwanted effects of these drugs, such as the extrapyramidal side effects in the high-potency drugs and the anticholinergic and sedating side effects in the low-potency drugs. So that as we pushed patients into the very beginnings of the therapeutic dose ranges for these drugs, we were entering the beginnings of the side effect ranges for these drugs as well. A real advantage of the novel agents is that the dose-response relationship for their therapeutic effects is separated by a substantial degree from the dose-response relationship for the unwanted effects.
In my mind, the real exciting and fundamental difference between the new atypical antipsychotics and the older typical antipsychotics is the older typical antipsychotics affected primarily dopamine neurotransmission in a nonspecific way. The atypicals are much more specific in how they affect dopamine, and in fact blocking it in areas where it's excessive and increasing it in areas where it's deficient. But also they are able to modulate other systems that we think are dysregulated in schizophrenia, like the serotonergic systems, the noradrenergic systems, the glutamatergic systems, possibly the GABAergic systems, so that although they tend to have much more complex effects on the brain, we believe those are much more desirable in terms of treating the fundamental abnormality in the brain.
Clozapine, the first atypical licensed in this country, does in fact produce anticholinergic side effects. However, the likelihood of achieving a therapeutic effect at a dose below that which produces anticholinergic complications makes clozapine attractive in selected patients. Moreover, clozapine is relatively free of EPS, so the addition of anticholinergic drugs is unnecessary.
Even though we know that clozapine does bind to and affect some cholinergic receptors, it seems to be a different set of receptors and to not be the same pattern of anticholinergic side effects that we see with the anticholinergic anti-Parkinson drugs.
The advantage, I think, of clozapine over, say, some of the more classic low-potency medications is there's essentially no extrapyramidal symptoms associated with clozapine, or it's very rare. So consequently, there's not the need for adjunctive anticholinergic side effects, but it has a great deal of anticholinergic properties in its own regard. And I have seen, for example, elderly patients develop anticholinergic delirium with clozapine, so it does have to be used cautiously in certain patient populations.
Clozapine does not seem to decrease the production of saliva, one of the earliest and most obvious anticholinergic effects of the anti-Parkinson drugs. Clozapine also seems to produce a lower frequency of the other peripheral anticholinergic side effects, such as constipation and blurred vision, difficulty urinating. The central effects of clozapine also do not seem to be of exactly the same pattern or the same severity.
However, clozapine is employed as a second-line agent because it can cause agranulocytosis. Current recommendations restrict use to those patients who have not responded to or tolerated at least 2 other antipsychotic therapies. Unlike clozapine, risperidone, another atypical agent, is not associated with agranulocytosis. It also acts on a different set of neurotransmitter receptors. This activity may explain why risperidone is relatively free of anticholinergic side effects.
It's correct that risperidone is believed not to have any anticholinergic side effects that are appreciable, at least as seen clinically or even in vitro. And in addition, it tends to have very low extrapyramidal side effects.
For the great majority of patients, we can find a risperidone dose where an individual patient will get good therapeutic efficacy with essentially no extrapyramidal side effects. Now, if dose is pushed up from that point, certainly we'll see extrapyramidal side effects with risperidone. But I would urge a strategy in which we select doses for individual patients that are below the range that are producing extrapyramidal side effects.
The advantages of the atypical drugs can be negated by either starting with too high a dose or pushing the dose too rapidly. In otherwise healthy patients, the starting dose of risperidone is 1 milligram twice daily, but initial doses should be no higher than 0.5 milligrams twice daily in the elderly. Upwards titration should be slow in both groups, and maintenance dosages above 8 milligrams are discouraged. The reason is that side effects are likely to defeat the key advantages of this drug. Recent data show that more than 95% of patients on risperidone receive a daily dose of 6 milligrams or less. Starting and maintenance dosages of clozapine should also be conservative. The recommended starting dose is 12.5 milligrams once or twice daily. The daily dose should be increased by increments of 25 to 50 milligrams. In the elderly or other fragile patients, upwards titration should be more conservative, with an initial daily dose no higher than 12.5 milligrams and daily increases of 12.5 to 25 milligrams.
In fact, an argument can be made that if a dose is pushed with a new atypical agent to a point where there are side effects, extrapyramidal side effects, that would lead us to want to add an anticholinergic drug, that in fact we've overshot the optimal dose for that patient. And the right answer is to step back a little on the dose, to get it back down to where that drug is tolerable for the patient.
This observation is important because the narrow margin between efficacy and toxicity among typical agents has sometimes encouraged clinicians to approach dosing from the standpoint of toxicity rather than efficacy.
One of the approaches that has been looked at for use of antipsychotic drugs is to titrate and dose up in individual patients until you hit a minimum level of side effects and then to perhaps back away a bit. This can be a useful strategy for some patients. With the conventional drugs, the evidence suggests that the point at which you hit minimal side effects is very close to the minimum dose that'll give you therapeutic efficacy.
One particular reason to be concerned about overshooting the dose of atypical drugs is that it may take longer for these agents to exert maximum benefits. This is an area of ongoing research, but recent studies suggest that therapeutic benefits on a given dose increase over a period of at least 3 months.
The best literature that I'm aware of is for the typical antipsychotics. You should see a response within about a month to 2 months, and John Kane's group has done a lot of data in that regard, that in prospective studies with the classical high-potency antipsychotics, what response you see after about a month is about what response you'll get. With the atypicals, there's, particularly with risperidone, there's good data that you continue to have an appreciable increase in clinical benefit over a period of at least 3 months, meaning that if you prematurely raise the dose, you will miss some responders that would have responded to a lower dose.
We certainly would not want to take a strategy with those drugs, the atypical drugs, of titrating dose up to where we hit some side effects to show a pharmacologic action of the drug. We know the dose range in which most patients with chronic schizophrenia will get a good therapeutic benefit with a new drug like, for example, risperidone. That dose range for most patients is 4 to 8 milligrams a day. If we bring a patient's dose into that range and wait a week or two, and the patient seems to be recovering nicely, and there are no side effects, then I would argue that there's nothing more to do. We're getting what we want, therapeutic efficacy. We don't have side effects, but we don't need them.
Differences among the mechanisms of action of antipsychotic drugs are being scrutinized carefully. All effective antipsychotic therapies exert some blockade of the dopamine D2 receptor, which has led to the dopamine hypothesis of symptom control. However, activity at other receptors and the relative strength of this activity probably explains how drugs differ in regard to both benefits and risks.
One of the main differences between the low-potency antipsychotics and the high-potency antipsychotics are that the low-potency drugs are sloppier. By that I mean they act on a number of different neurotransmitter systems, whereas the high-potency drugs, which we refer to as cleaner, act in a focused manner on the dopamine system.
There is evidence that a broader spectrum of activity on neurotransmitter systems may be beneficial when it's targeted at appropriate receptor sites. But one of the neurotransmitter systems upon which low-potency drugs act is the cholinergic system itself. It is direct blockade of acetylcholine that is held responsible for many of the most common side effects associated with these agents. In contrast, some atypical agents, while exerting little cholinergic blockade, demonstrate significant activity on the serotonergic system, particularly the 5-HT2 receptor. This may have several advantages.
With the new atypical antipsychotics, to me, the defining difference, or at least one of the major defining differences, is their ability to block the 5-HT2 receptor. The advantage, which does not occur with the older classical typical antipsychotics, that not only reduces the frequency of extrapyramidal symptoms, but it also is believed to improve negative symptoms of schizophrenia, the anhedonia, asociality, types of symptoms that make patients so functionally impaired even after you've treated their positive symptoms, their hallucinations, delusions, and thought disorders.
However, it appears that clinical effects are not only dependent on activity at specific neurotransmitter receptors, but on relative activity, especially in different regions of the brain.
It's believed that the atypical antipsychotic's ability to block serotonin releases dopamine in dopamine-deficient areas, which could include the nigrostriatal system and consequently reduce or prevent extrapyramidal symptoms and possibly reduce or prevent tardive dyskinesia. In the prefrontal, or so-called mesocortical system, releasing dopamine in that area may directly improve some cognitive functions and some negative or deficit symptoms. In addition, we're developing essentially a new language of psychopharmacology with the atypical antipsychotics, and they have other properties. For example, blocking the alpha-1 noradrenergic receptor and the alpha-2 noradrenergic receptor. Blocking the alpha-1 noradrenergic receptor may have some beneficial effects on dopamine neurotransmission in the brain. The alpha-2 receptor, which is blocked by medications like risperidone and clozapine and some of the atypicals, but not all of them under development, is believed to increase norepinephrine in the brain, increase the release of norepinephrine in the brain, directly treat negative symptoms of illness. So that's a desirable property that you see with atypical antipsychotics that you don't see with typical antipsychotics.
The relationship between specific neurotransmitter activity and the clinical effects of antipsychotic drugs remains largely theoretical, but research is advancing rapidly. At Dr. Rish's institution, neuroimaging is being employed by Dr. Mark George to map the specific effects of antipsychotic agents and correlate these effects with clinical course. His work is helping to unravel a complex story.
A number of prominent researchers around the country have been interested in the role of glutamate in schizophrenia, and there's an evolving hypothesis that glutamate is deficient in many patients with schizophrenia. Dr. Olney at Washington University in St. Louis has pioneered this, among others. Many of the atypical antipsychotics are believed to have partial glutamate stimulatory activities, which may markedly improve the prognosis of the illness in terms of treating the underlying psychosis and possibly attenuating neuronal cell loss or neuronal cell death that may occur in the absence of glutamatergic stimulation. And to me, this is one of the most compelling and exciting areas of research in schizophrenia.
Activity at other neurotransmitters does not negate the importance of blocking dopamine. However, current research points to an interrelationship among neurotransmitters. This interrelationship suggests that improvements in both therapeutic efficacy and safety will be achieved by drugs that go beyond dopamine blockade to target the mix of receptors which provide the most benefit with the least risk.
There's very compelling evidence that dopamine is abnormal in the brains of patients with schizophrenia, and this may be due to abnormalities post-receptor, in other words, in terms of interneuronal processing at the level of second messenger systems like cyclic AMP or the phosphatidylinositol system, G protein regulation of those systems, or even in terms of direct effects at the DNA level in terms of CFOS and so on. And there are differences among atypicals and typical neuroleptics in the effects of these interneuronal cellular systems. We now know that a number of other neurotransmitter systems affect dopamine, and specifically acetylcholine affects dopamine neurotransmission, serotonin affects dopamine neurotransmission, norepinephrine affects dopamine neurotransmission, and glutamate in particular, and GABA affects dopamine neurotransmission. So fundamentally, you could have an alteration in any of those systems, which could secondarily affect dopamine neurotransmission, and the primary pathogenesis of schizophrenia might be around those modulatory systems and not directly at the dopamine receptor level.
Differences in risk of anticholinergic side effects among specific populations may eventually be explained by differences in these modulatory systems. But the disparities in risk have immediate clinical relevance.
Young individuals have not had prior exposure to dopamine blockade and the multiplication of dopamine receptors that that prior exposure produces, and they're very sensitive to their initial experience with dopamine blockade. So they may hit extrapyramidal side effects at doses well below those we're accustomed to needing for patients, young adult patients with chronic schizophrenia. Another group of patients are the elderly. We know that the elderly are very susceptible to memory impairment, to confusion with anticholinergic drugs, as well as a substantial susceptibility to the peripheral side effects of these drugs. So in elderly patients who need treatment with an antipsychotic, if we can spare them that anticholinergic burden that will impair their cognitive function, that will worsen their constipation, that will make it more difficult for them to evacuate their bladder, we're improving the overall quality of their life, quality of their cognition, quality of their function.
High-potency agents have well-established efficacy and have been a mainstay of pharmacologic control of psychoses. However, the relative risk of anticholinergic side effects is considered to be an impetus to consider atypical agents as a valuable alternative, particularly in patient populations with pronounced susceptibility to these complications.
I believe there are certain subgroups of patients in whom it's such a valuable achievement to avoid anticholinergic side effects that we should strongly consider using an atypical antipsychotic as a first-line treatment.
Consistent with the goal of returning patients to a quality of life as close as possible to the one they enjoyed before their illness, significant attention has been turned to the potential devastating effects of cognitive impairment stemming from anticholinergic side effects. Dr. McAvoy is among those who have demonstrated that anticholinergic drugs impair the ability to put new material into memory. He considers the addition of anticholinergic drugs contraindicated in young individuals in whom memory loss has implications for quality of life and outcome.
Young individuals who are having an initial episode of illness, who, if identified early and treated early, have an excellent likelihood of a really good recovery, excellent remission of symptoms, and the capacity to resume a life very close to that which they had before the onset of the first psychotic episode.
The modern era of pharmacologic treatment began almost 50 years ago with the development of the first effective neuroleptic therapies. There have been incremental clinical advances since that time, but a rapidly expanding understanding of the impact of neurotransmitter systems on both the risks and benefits of antipsychotics may mean a reorientation in clinical goals.
In my opinion, the reason I became interested in schizophrenia in my career was the development of the atypical antipsychotics, both from a scientific area of interest, but also from a clinical efficacy. I've been doing this for about 20 years now, I saw for the first time patients who were chronically unhospitalized get dramatically better. Granted, not everyone does, but a significant number of patients who appeared to be hopelessly ill suddenly recovered, and to me as a psychiatrist, look well, so that I believe they've made a huge impact on the efficacy of treating the illness, quality of life for patients, and they've begun to make a huge impact pharmacoeconomically on cost savings in terms of keeping patients out of the hospital, improving their ability to re-enter the workforce.
First, we had the low-potency agents that had intrinsic anticholinergic activity in every patient who took them. There was a small advance when the high-potency drugs were developed that could produce their antipsychotic efficacy, and then independently we could adjust anticholinergic dose to deal with extrapyramidal side effects. But still, for most patients, we had to add an anticholinergic drug. We had to bear some burden of anticholinergic side effects. We now have a whole new ballgame.
Recent developments have led clinicians to more aggressively seek therapeutic regimens that minimize or entirely circumvent side effects. Atypical agents may not entirely supplant typical drugs, but clinicians can now envision formularies that do not require anticholinergic drugs to control EPS. This is because alternative regimens are available when EPS develops.
We're just crossing the threshold of an era in which the anticholinergic drugs will hopefully slowly be passing out of our pharmacies. We won't need them anymore, just as they're hardly used anymore in the treatment of Parkinson's disease.
The Dana Miller Memorial Educational Foundation is accredited by the Accreditation Council for Continuing Medical Education to sponsor continuing medical education for physicians. The Dana Miller Memorial Educational Foundation designates this continuing medical education activity for 2 credit hours in Category 1 of the Physicians Recognition Award of the American Medical Association. The Dana Miller Memorial Educational Foundation is a provider by the California Board of Registered Nursing, provider number 04229. This program is approved as a continuing education activity for 2 contact hours. Texas Pharmacy Foundation is approved by the American Council on Pharmaceutical Education as a provider of continuing pharmaceutical education. ACPE number 154-999-96225H01 for .02 CEUs. The Dana Miller Memorial Educational Foundation is solely responsible for the content of this continuing medical education activity. This Milestones in Medicine Learning Kit is funded through an unrestricted educational grant provided by Janssen Pharmaceutica.